Hello there, my name is Kamran Bhopal. I'm back with a series of ST3 National Training Interviews histories, and today we're going to go over the history of a scrotal mass. So basically the station is related to testicular cancer. I'm going to present it the way I presented it, and then you can see how long it takes and you can adjust it according to yourself. So the scenario comes, you've got this 24-year-old man or 30-year-old man with a testicular lump. He's been referred to you by the GP. How would you assess him? And now comes your history part. And you should ideally aim for about 2 to 3 minutes, and that's the maximum, because then you have to move on to questions as well. So I'm going to start it now as I am the interviewee, and you can sort of gauge how the pace should work and what are the salient points to include in this. All right. So I would like to see this patient as soon as possible in my urology 2-week wait clinic. I would check the referral letter and any previous investigations that have been done. And I would also confirm the patient's understanding why he has been referred and check his identity. A testicular lump is testicular cancer until proven otherwise, and my assessment will focus on that as my primary differential, taking in account risk factors and red flags for testicular cancer. My history will include the onset, duration, and progression in the size of the mass, whether this is a painful or a painless mass, whether there is any associated symptoms of urinary tract infection, such as frequency, urgency, dysuria, foul-smelling urine, if there's any sexual history, penile discharge, symptoms in the partner, any history of trauma, and any past surgical history of orchidopexy. I would then like to rule out any red flags in this patient, such as night sweats, shortness of breath, weight loss, anorexia, and bone pain. I would then risk stratify for testicular cancer, which will include, number 1, history of cryptorchidism, family history, especially brothers and fathers, race, since this is more common in Caucasians and Scandinavians, DES exposure, which is maternal estrogen, although the history may be difficult to elicit, subfertility or poor spermatogenesis, contralateral testicular cancer history, and lastly, HIV history. I would check whether the patient has completed his family, and I will ask him for any medications such as anticoagulants, any allergies, smoking history, and performance status for surgery. I would close the history asking about the patient's ideas, concerns, and expectations. So yes, this is my way of presenting the history, and this is how I would take a history of testicular cancer. And then they would sometimes say, okay, how will you examine this patient? Or if they don't and they want you to go on, if they say, how would you assess the patient? It's a bit of a broad term, so you can just jump straight on from history and they will stop you if they don't want to listen this examination. So you just say, and then in the presence of a chaperone, I would take consent from the patient and examine the patient. My general examination would include looking for any signs of Klinefelter's or Kalman syndrome, any supraclavicular lymphadenopathy, chest exam, any gynecomastia, any retroperitoneal masses, any inguinal scars indicating childhood orchidopexy, and then I will move on to a focused testicular exam starting from the contralateral side, looking for the size, shape, and symmetry, and then feeling for warmth, tenderness, fluctuance, firmness, irregularity, and involvement of the cord above and the scrotal skin. And I would then also check for inguinal lymph nodes. So this is just a line, they're not wanting you to go into too much detail, but you've sort of told them that you know about what syndromes are related to this, the signs of metastatic disease you've picked up, and then that you've done a proper testicular exam and also ruled out other things such as infections and other testicular pathologies, but you should be focusing mainly on size, shape, irregularity, those sort of things. They're just basically looking at whether you've safely excluded everything and also looked for signs of metastatic disease, and especially involvement of the cord and scrotum is important, as the grading and staging if you read about it. you will know that how these are all actually linked with how you stage the disease. So it's good for the examiners to know that the person knows what he's talking about when examining, and he's also staging the person whilst he's examining them. But this all needs to be very precise, as I've said. So this is your history and examination, and we'll stop here, and then we will have a separate session where we would go into details about what questions they can ask in testicular cancer. Good luck, and I'll see you next time.